All right, guys. Night 2. We're covering Chapter 2 tonight. We're going to be talking about the well-being of the EMT. So tonight's discussion is going to be your personal safety, your partner's safety, maintaining a healthy lifestyle, stress management, all that fun stuff. All right. A little bit of a long presentation tonight, so we will have a break in between here. At any point, if you have a question or anything, just raise your hand and let me know. We'll talk about it, okay? You can follow along if you want in your book. It's Chapter 2 of your book if you want. This highlights more of the main points in your book. So your book's going to go into a lot more detail. So after tonight's lecture, you can go onto My Brady, use the electronic form of the book, or use your personal book there. All right. So, topics for discussion tonight. We're going to talk about the well-being of the EMT, maintaining a healthy lifestyle, maintaining safety, personal protection, the different types of personal protection equipment that you're going to be used. Those are good NR-EMT questions, so really kind of pay attention to that one. Diseases of concern, maintaining and managing stress and emotions, and then scene safety. Scene safety is something that we're going to drill into you guys throughout this entire class. If you look on your psychomotor exam, the first points on there, scene safety, BSI. So this is the first part of all that. Okay. So importance of well-being. Keeping yourself prepared for demands and risks of EMT is very important. So you need to protect yourself. It's the first part of when we go to a call. We need to maintain our own safety. If you're unable to function for any reasons, patients will suffer from your cause. So if you are driving 90 miles an hour down the road and you get into an accident, well, now you need to pull a crew to take care of you, and now you need to send another crew to that call for that patient. So it doesn't do the patient any good. So maintaining yourself, maintaining your partner's safety, those are all important things. Maintaining solid personal relationships, so maintaining a solid relationship with your working partner, with your staff, with your community, with the hospital, all important things. When we're talking about the care of a patient, really being able to work with your partner. We kind of work together all the time, and some people we work with, we don't even communicate. We know what each other's doing. Like Joe and Derek work together all the time, and it's literally one's on a set of vitals, one's asking questions, and you really get in sync. Exercise. It's a good, healthy habit to exercise every day if you can, at least 30 minutes a day, getting your heart rate up to a target level. It's dependent on your age and weight. Those are all good things to do. We're going to talk about some different exercises. Sleep. This is an interesting one. It is good to get a healthy amount of sleep, at least 8 hours every night if you can. In this field, we work 24-hour shifts. Unfortunately, that's not always a commodity. So nights before your shift, making sure you're getting adequate sleep. If your service allows, while you're on shift, getting some sleep to kind of prepare for the night is very important. Eating right. This is another one. Eating a healthy, balanced diet. This is all important for your cholesterol levels, your blood pressure, your energy levels, all that kind of stuff. If you're not eating right, it's going to wear you down later on. So eating a good, healthy diet, we're going to talk about that a little later in this lecture. Limiting alcohol and caffeine intake. Obviously, you're not going to go to work or go to a call intoxicated. Caffeine is a form of a drug. It's a stimulant. If you can become dependent on caffeine, most people drink some form of tea or coffee in the morning to kind of wake yourself up. But you don't always want to be dependent on caffeine to keep your heart rate up and keep you energetic. Seeing your physician regularly and keeping up to date on vaccines. So an annual checkup with your doctor, maintaining your own health, and keeping up to date with your vaccines, whether it's Hep B, the flu, COVID, all that stuff that protects you because we encounter sick people. Personal protection. So pathogens. If you guys have heard the term before, a pathogen is an organism that can cause an infection, whether it's a bacteria, a fungus, a virus. Those are all different forms of pathogens. Pathogens can be bloodborne or airborne. a bloodborne pathogen. An example would be hepatitis, HIV. Those are different forms of bloodborne pathogens. Airborne pathogens. A good example would be either pneumonia, COVID, the flu. Those can all be transmitted through airborne. Standard precautions include steps to protect yourself from pathogens. So wearing gloves, wearing a face mask, wearing eye protection. Those are all important to protect you from other individuals. And make decisions about which standard precautions to use based on the situation you're presented with. And we'll get into that. So the Occupational Safety and Health Administration, OSHA, they're the governing body for safety and commission of every business organization. They have issued strict guidelines about precautions against exposure to bloodborne pathogens. So annually, every year, I'm pretty sure with every service, it's a requirement that you go through a bloodborne pathogen training, an airborne pathogen training, wearing personal protective equipment, and then what to do if you are exposed. Refer to your local protocols for wearing personal protective equipment. Our protocols have changed since COVID has come about. It used to be before COVID, it was basically gloves, eye protection, and a face mask as needed. Since COVID hit, it was required that we had to wear gowns, N95, with a face mask over the N95, eye protection, and gloves. So literally every patient we went to, we had to put all that stuff on first. Since then, they have relaxed it a little bit. Most EMS providers have gotten vaccinated, so now they've kind of lowered our requirements, and we'll talk about that. Written policies within your organization will address what to do if you're exposed. So per the state, your organization has to have set standard guideline as to what to do if you are exposed. With AmCare, the first thing we do is, obviously, if you get exposed, you need to wash your hands or wherever you got exposed, cleanse the area, notify your supervisor, and then notify your infection control officer. And then from there, depending on what you got exposed to, sometimes you have to get blood work done, and the individual that you were exposed by has to get blood work done as well. So there's a whole process to it. So making sure you keep yourself safe is kind of the key to this whole thing. So personal protective equipment. This is kind of the standard stuff that we use. Obviously gloves. Now, for the most part, we wear nitrile gloves. Latex has kind of fallen out because of allergy development from latex. Eye goggles, face shields, and then N95s. Has anybody in here ever had to wear an N95 before?
Yeah.
Okay. They're not fun. They're sometimes hard to breathe in. They're important because they actually protect us from what we take in. These surgical masks don't protect us necessarily from you exposing me. It's protecting me from exposing you. Okay? So that's kind of the main thing. So that's why we always put a face mask on the patient so we can protect ourselves. So every call we go to, we always wear protective equipment. You should never touch a patient without a set of gloves on. That's period, point blank. You always want to be wearing gloves because you don't want to catch whatever the patient has. So protective gloves, that's our first thing. When you go into your psychomotor exam, first thing you say, BSI, body substance isolation, okay? If you state that you either walk into your test and you're wearing gloves, or you state you're going to apply protective equipment, they will count that point for you. That is a critical fail if you don't say that or do that, okay? So with protective gloves, we always wear vinyl non-latex gloves. Gloves should be changed between patients. That's kind of a given. We're never going to go from one call to the next wearing gloves. Whenever if you're going to drive the ambulance from the scene, you're going to take your gloves off. You're not going to go to the front of your ambulance, hold the steering wheel with your gloves on, right?
I would make a point that you should change your gloves actually a couple of times with each patient.
Yeah, that's a great practice, yep.
I do. I typically change my gloves after starting an IV and whatnot because you usually always get blood on it and it keeps from contaminating your other equipment.
Exactly. So. Just think of, if you touch the patient, everything you touch with those gloves on after the patient is exposed, okay? So that takes up time to decon, all that good stuff. So changing your gloves frequently, washing your hands frequently. Those are all key things.
Garrett, can I interject something?
Go for it.
The other thing to keep in mind, like when you're wearing gloves after touching a patient, try not to touch yourself, like, you know,
Yeah.
like your eye itches or something, like mucous membrane and stuff like that, so try not to stick that in your, I know, like, usually isolation rooms, for whatever reason, my ear itches, and it's like, it's some kind of psychosomatic thing, but try not to touch your, you know, mucous membranes with your gloves on.
Yeah. If you do need to itch your eye or anything, take your gloves off. I carry solution with me, so anytime I change my gloves, I isopropyl my hands, and then if I have an itch or whatever, I need to touch something, my hands are cleansed.
That's actually, sorry. To bring up another thing, you're going to use enough hand sanitizer in this business that your hands are going to dry out frequently and often.
Yep.
So get used to carrying like a little bottle of like hand lotion on you in your bag that you bring to work and stuff. I keep a bottle because my hands break up and crack and everything like that multiple times a year. So keep that in mind.
Yep, definitely. That's a good point. Wear heavyweight and tear-resistant gloves when cleaning the ambulance and soil equipment. So they do make two forms of gloves. Since COVID hit, we've been kind of restricted as to what gloves we can get. It's basically whatever the state supplies us with, that's what we have. So we make do with what we have. You know, if that means you need to put 2 layers of gloves on, then do that. That's not an issue. But you should always, any contaminated surfaces, whether it's a surface or the patient, you should always be wearing a set of gloves. So this is an example of donning and doffing a set of gloves. We'll actually practice this with you guys. It does take somewhat of a technique. It seems kind of funky at first. Has anybody performed donning and doffing procedures with gloves? So the biggest thing is dirty touches dirty, clean touches clean. Okay? So what this individual is performing, he's taking his gloves off where he's not touching his clean hand with his dirty glove. Okay? And we'll practice that with you guys. Same with gowns, face shields. There's a whole procedure to doing that. Hand washing. This is a given. Anytime you take your gloves off, you should be performing hand hygiene. Hand washing is the golden standard. Scrubbing vigorously with soap and water for at least 30 seconds, and then drying your hands off once you're done. Alcohol-based hand cleaners are also effective. They're considered effective by the CDC. Alcohol-based hand sanitizers can be used if soap and water are not available. So soap and water is the gold standard. The hospital up at Northwest, that's the first thing we do after we pass off patient care. We've cleaned the ambulance, we go in and wash our hands. Okay? Every call. So using a careful methodical hand washing is effective. It reduces our exposure to contagious diseases. There are some situations where you're all the way up above your elbow. Sometimes we go to really bloody traumas. You know, blood gets everywhere. So if it takes extra time, you know, you do what you have to do. Sometimes you have to bring in an extra uniform. If you get blood on your uniform, change your uniform, throw it in the wash, and then go about the rest of your day, basically. Alcohol-based hand cleansers are effective and often available when soap is not, or water is not. Every ambulance carries some form of alcohol, making sure you scrub your hands thoroughly each time. Eye and face protection. Eye protection prevents splashing into your ocular space. It prevents spattering or spraying of fluids. That is one form of transmission that can enter your body. Is through your eyes. It should provide a guard from the front and sides, so COVID is a good example. That's why we wear face masks with COVID positive patients. If they're coughing, water droplets can actually enter through our eyes. So using eye protection for, at least right now, during times of COVID on every call. Masks. So there are multiple forms of masks. The minimal that we use right now is at least a surgical mask. The state of Vermont has put out, initially when COVID first hit, it just had to be any form of a face mask. Joe and I went and spent quite a bit of money on good face masks, but the standard came out that it had to be surgical masks.
A week after we bought them.
A week after we bought them. So surgical masks are the requirement by the state. Anybody that's suspected to be COVID positive, then we have to wear an N95. So in cases where there will be blood or fluid spatter, wear a surgical type mask. This was kind of made before COVID hit, so right now it's a surgical mask at minimum on every call. In cases where tuberculosis is suspected, you're to wear an N95 or high efficiency particulate air, a HEPA filter, respirator approved by the National Institute for Occupational Safety and Health. So NIOSH. So Joe actually has one of these.
I go get it.
Yeah, if you want to show them. You can buy them online, a HEPA filter. Your service is required to provide you with at least an N95. You do need to be fit tested with the N95 before you can go out in the field. So once you've been fit tested to the correct size N95, then you're good to go with that size N95. The HEPA filter is actually a little better. Joe's going to grab his. It's a little more effective. It looks like a Star Wars face mask, but it's really effective in protecting you.
Don't you have to get fit tested with that too, though?
Yes. Yep. Any one of these you do have to get fit tested. Yep. Good question. Face shields offer protection of the entire face, so there are surgical masks that have a face shield to go above. That is a good form of eye protection. We also have face shields that we wear across our forehead and come down in front of our face, and that's also a good form. Any questions with those? So this, we call it a duckbill. This is a form of an N95, so basically individuals who can't fit a regular N95, this is really effective for those individuals. This is a HEPA filter.
It's my Bane mask, for anyone that's seen the Batman movies.
So he's basically got filters that are interchangeable on both sides. So he doesn't have to throw the whole mask away, he can change out those filters. I don't know how often you have to do it, but...
They're good actually for quite a while. Basically until you can kind of see the white in there, in between them. So basically once they start kind of looking dirty, that's when you're supposed to kind of throw them out. So it's kind of subject to how much you use them and whatnot. But I went and bought this because N95s are starting to drive me insane. They're starting to just become uncomfortable. So this is much more comfortable. It sits on the crown of my head, and it has a speaking diaphragm on it. So my partners can actually hear me talk.
Yeah.
So, but yeah, it's way more comfortable than N95 masks are.
Yeah.
So.
And it's personal preference. You can purchase those online. Most services don't provide those.
This is about an $80 setup.
Yeah.
So
personal preference, if you'd like to use one or not. Again, there are multiple forms of N95s available. This is one of the styles that is available. Before you can use it, you do have to be fit tested for it. So wearing protection, including a mask or face shield when suctioning a patient. So when you think about when you suction a patient, what are you being exposed to? Fluids, exactly. Whether it's the suction canister, if you're down close to the patient's face, when we're intubating a patient, any form of airway procedure, you should be wearing at least a face shield, okay? And N95 is recommended as well. And the big thing with that is fluids will spatter. Patients who are vomiting, that's a big thing. Those fluids you will be exposed to, so you need to make sure you have the proper protection from it. So he's wearing one of the surgical masks that also has a face shield attached to it. Your other option is the face shield that's separate from it and comes all the way down below your chin. But anytime you're performing any one of these procedures, you should be wearing a face shield. Gowns. Gowns you may also wear a gown to protect clothing and bare skin from spilled or splashed fluids. It is highly recommended that you wear a gown during a trauma because there are a lot of fluids involved. Patients who are vomiting. We go into houses where there's feces all around, there's urine all around. It's a good idea. You want to protect your clothing, protect yourself. And again, if you didn't wear a gown during the call, if you have an extra set of gear with you, change your gear, put your gear in the wash, just to protect yourself. And the other thing I will say with that, when you finish your shift and you go home, some services allow you to leave your gear at the station, but the first thing you should do when you get home, if you don't leave your gear at the station, throw it in the wash. Okay, don't wear your gear around in your house because everything you just did during that shift, you're now bringing home, and you're bringing it to your family. So really protect yourself, protect your family. That's the first thing you do when you get home. Wear a gown if a patient has an arterial bleed, in childbirth, or has multiple injuries. So there's a lot of blood involved with every single one of those. Arterial bleeds, they spatter. So until you stop the bleed, it's going to continue to spatter. Childbirth, again, another one. A lot of fluids involved. So really wearing a gown is important. So any questions with personal protective equipment? I will tell you during COVID, we are required to wear a gown with any suspected COVID positive patient. Okay? If we're going to an ankle injury, the patient has no COVID risks, then we don't have to wear a gown going to the patient. But any potential COVID positive patient, it's gown, gloves, N95, surgical mask over it, and a face shield. Okay? Alright, so diseases of concern. So we're going to start getting into different pathogens, bloodborne, airborne, all that good stuff. Hepatitis B and C. It is an infection that causes inflammation of the liver. So it affects your hepatic cells of the liver. Hepatitis B is a deadly virus. Prior to the vaccine available to it, multiple healthcare workers were actually killed by the virus. The hepatitis B vaccine is available to everyone. Most employers do inquire if you have your Hep B vaccine or not. It is highly recommended. It can live on surfaces in dried blood for several days. So the patient, you touch a surface that blood was contaminated on, it can live on that surface for multiple days, and it can put you at risk.
How often do you need the vaccine? Is it one time only?
I believe it's a one-time deal. There's no booster for it that I'm aware of.
Okay.
Yeah, it's a one-time deal. So yeah, the Hep B vaccine is available and recommended. Hepatitis C, there is no vaccine available for it yet. It does pose the same risk. It's not really as deadly as Hep B, but it can be. There is no vaccine available for it yet, so that's why doing thorough hand cleansing, going through the right protocols if you're exposed, all that kind of stuff.
Now there is medication for Hep C, but it's like a
Yes.
6-week
Yep,
thing.
it's a 6-week kind of antiviral course, symptom management. It is 100% manageable. Medicine has come a long ways since they first discovered hepatitis C. So it's not to say you have a death sentence if you ever got exposed to Hep C. It's nothing like that, but it's just something to be aware of. Any questions on Hep B or Hep C? Tuberculosis. This is something that's still out there. It's not very common. Tuberculosis has kind of gone away. It's more common. It's seen somewhat in prisons from time to time. But typically it'll be a known outbreak, and typically you know about it before you go to the patient. So tuberculosis, it's an infection of the lungs. It is highly contagious. It is contagious when the individual is in the active form of tuberculosis. So there's an active and an inactive form. That individual would have to be in the active form for it to be contagious. It is passed through the air. Through air particles. When the patient breathes, you then inhale those air particles and it can affect you. The one thing I will say about tuberculosis, any patient that is suspected to have TB, N95 needs to always be worn with these patients, along with gown, gloves, treated just like a COVID patient.
Is that like mono where it can like reappear again? And
Yes. Yep, exactly. Once you catch tuberculosis, it stays in your system. You just go to an inactive phase. So if you ever did get diagnosed with tuberculosis, they would do annual chest x-rays to look at your lungs and make sure it's not becoming inflamed and becoming an active form. So some people do live with tuberculosis their entire lives. It's just all about symptom management and managing the virus.
A lot of employers prior to through your hiring phase will require a TB titer or a test. It's a really simple test. They inject like a little thing under your skin, and If that goes crazy, then you have TB. If it goes
Yep.
away, you don't.
Yep.
So it's pretty simple, but a lot of employers will require that.
Yeah,
getting
employers,
healthcare.
college, different courses, they all require a TB test before you can attend college or work. So yeah, and even if you did come back positive on your TB test, that doesn't necessarily mean you're going to die. That just means at some point you did get exposed to TB. They would then do a chest x-ray to determine, do you have an active form of TB or is it an inactive form that's just living in your bloodstream? Okay.
Does that disqualify you from a lot of employment?
Not necessarily.
Not necessarily, yeah.
Nope. That's where they would determine if you have the active or inactive form.
Gotcha.
They determine you have the active form, then they would be like, you need to go see your healthcare
Yeah,
provider
yeah.
before anything.
Find a sanitarium somewhere dry.
Yeah. Pretty
Like
much.
back in the old west.
Yeah. So, any questions with tuberculosis? Your book goes into a lot more depth on it. We're just kind of highlighting the main points. So remember, tuberculosis, infection of the lungs; hepatitis, infection of the liver. Okay? AIDS. So AIDS, in its early stages, starts out as HIV. It attacks our immune system, leaving the patient unable to fight off the infection. HIV is still out in the community. At some point in your career, you will take care of an HIV patient. That doesn't mean you need to stay 10 feet away from them at all times and that kind of stuff. You are at some point going to have to start an IV on them. It's really just protecting yourself, making sure you're wearing the proper equipment, and doing thorough hand washing. So HIV, again, it attacks our immune system. It kills it basically kills all our T cells, which work to fight off pathogens. So that's kind of in the early stages. How they diagnose you is they look at your white blood cell count. As it becomes more active, your white blood cell count decreases to the one point where it reaches the AIDS stage. So AIDS is a set of conditions that results when the immune system has been attacked by HIV. Okay? So the early stages is HIV. It can then progress to AIDS.
Garrett, can I interject?
Yes.
So the interesting thing about HIV or AIDS, as far as like decontamination,
Yep.
so Hep C lives on surfaces for days and like up to weeks. HIV, when it's outside of the host, dies in like seconds. So it's
Yep.
not like it's a little safer, I guess, when deconning. So it's just something to keep in mind. It's still use standard precaution, but like hepatitis is almost more like as far as deconning more of a concern. So.
Right, exactly. And the other thing about HIV, so let's say you incidentally get stuck by a needle from an HIV positive patient. The risk factor, so I stick a needle into a patient with HIV and then I get stuck with that same needle. The risk factor of actually catching HIV at that point is less than 40%. So risk is very minimal. It is a chance, and that's why if you do get exposed, the first thing you do is you cleanse the area that you got exposed to, okay? And then you do follow-up blood work. But other than that, so the risk is really kind of low, as Eric said, but just being aware of it. So AIDS, lower risk for healthcare workers than hepatitis or TB, kind of what Derek said. It is out in the community, but just using our standard precautions will protect you from it. And it is transmitted through contact with blood is the usual route of infection. Okay? Specific diseases of concern. Ebola. Does everybody remember? Go ahead.
Sorry, that's what I was going to ask.
Yep.
When Ebola hit, did it hit out here majorly, or?
Not really, no. Actually, it didn't really hit here at all. I don't know of any cases that came out here. But it was one of those things, once Ebola hit, every single ambulance had to get an Ebola kit. The hospital had to set up staging areas for Ebola because we were basically planning for this big outbreak. It never happened. Kind of where COVID, we were somewhat prepared for COVID in that stance because we had all the stuff ready to go.
Right.
But Ebola in 2014 was a pandemic that hit more of the southern states. Didn't really affect us. And that, so Ebola transmitted into a hemorrhagic fever, high rate of deaths, and lack of definitive treatment. So it was kind of a new virus that we weren't prepared for. and there was a lot of deaths associated with it. So severe acute respiratory syndrome, or SARS, is spread through respiratory droplets. Is COVID a form of SARS? Yes, it is. COVID is a form of SARS. There was a SARS outbreak in 2017 or 2018. That was actually much more deadly than COVID. The only thing with that is it wasn't as transmissible. So there were, when individuals did catch it, there was a high mortality rate, but the numbers of individuals that were catching it were actually really low compared to COVID. So just like COVID, it's spread through respiratory droplets, and it's a severe acute respiratory syndrome, so it attacks our lungs. Middle Eastern Respiratory Syndrome, or MERS, it's found primarily on the Arabian Peninsula, so not something that's really hit over here in the US. Somebody who's traveled from that area, that's a good thing to be aware of, and something to keep in mind. Avian flu. So it's found in poultry. It can affect humans. It's not easily transmissible from human to human. Basically, since COVID hit, you've noticed, or may not have noticed, that influenza has actually kind of gone away. Our flu cases in this area have basically been non-existent, and that's all in part due to everybody wearing a mask. So the avian flu comes from poultry. It does affect us. It hits us just like the flu virus does. Similar signs and symptoms with a fever, typically a high heart rate. As for influenza, around for hundreds of years. There's a new form of influenza every year. That's why we get a flu vaccine every year. Basically, they plan ahead. There's usually 8 to 10 different flu viruses that go around that year. So basically, you have a 60% efficacy rate with your flu vaccine. In 1918, the pandemic from influenza killed between 30 and 50 million people around the world. So the Spanish flu, that was in 1918. That was one of the bigger pandemics we've had prior to COVID. And actually COVID kind of followed along the same lines as that virus did. Infection control and the law. So before we jump into that, is there any questions with any of these diseases? Your book goes into much more detail on them, but just so you guys kind of understand these different diseases and what systems they affect. So infection control and the law. EMS personnel and other healthcare workers are at high risk of coming in contact with infectious diseases. That's kind of part of the job. It's one of the work hazards we deal with. So that's the importance of protecting yourself. Guidelines for workplace safety developed by OSHA and the CDC. So having standard guidelines in place for exposure, having equipment available to you at all times, and using proper precautions based on your protocols and your training. Occupational exposure to bloodborne pathogens. So OSHA set a standard on bloodborne pathogens requiring infection control to be the joint responsibility of the employer and the employee. So that's why every year with your workforce, that's one of the things you have to go to. If there's a risk of exposure to bloodborne pathogens, annually you have to go through the OSHA training. EMS agencies provide training, protective equipment, and vaccinations to employees. This should always be available to you and keeping you from being at risk of being exposed to bloodborne pathogens. Employees participate in infection exposure control plan. So depending what service you work for, being aware of your infection control plan, knowing the steps required by you. And that's one thing that protects you. If you get exposed and you don't tell anybody or do anything about it, then your work's not going to be held responsible because you didn't decide to do anything about it, and now you're just harming yourself, right? So taking the proper steps, understanding what those steps are, will protect you. So infection exposure control plan, every EMS agency that you work for has to have this established. Adequate education and training, we do a training annually on this. Having the hepatitis B vaccine, or having it at least available to you. Wearing personal protective equipment. Knowing methods of control. doing your housekeeping, so deconning your truck and your station, labeling different equipment, so having set things labeled that have been exposed, what's considered sterile, what's considered clean. If you see an IV catheter that's out, not in its normal packaging, consider it contaminated, right? We're not going to take that and use it on a patient because now we're going to potentially give the patient an infection, right? And then post-exposure evaluation and follow-up. So this is kind of that thing I was talking about. If you are exposed, obviously after you cleanse the area, you need to notify your supervisor, notify your infection control officer, and then if you need to, be evaluated at the hospital. So if you get exposed to a bloodborne pathogen, they have to pull blood from you, they have to pull blood from the individual that you're exposed by. So basically they're looking for, does the individual have HIV? Do they have Hep B, Hep C? Do they have any bloodborne pathogens? And if they do, then you have to go up for follow-up care. And that includes going on HIV meds, that includes going on Hep medications. They are not fun. You have to be on them for almost a year, and then continued follow-up with your doctor. So really protect yourself is kind of the take-home here. Right. So the Ryan White Care Act. This is an important one. This is going to come up in your test. It allows EMS providers to find out if they have been exposed to potentially life-threatening diseases while providing patient care. So, how this works. If you're exposed by an individual, obviously there's HIPAA involved with that, right? So this basically set in kind of a standard act that if you're exposed by an individual, there's a requirement of that individual to receive lab work to protect you. Okay, so if you bring in a patient and that patient refuses to receive blood work in order for you to figure out if you've been exposed or not, that patient is required to provide the blood work or what's necessary. Designated officer gathers facts about potential exposures. So your infection control officer, that is their job to figure out who was the individual that was exposed and who were they exposed by. There are 2 notification systems: airborne disease exposure and bloodborne or other infectious disease exposure. So these are under 2 different classifications. Once notified of an exposure, the employer will refer you to a healthcare professional for evaluation and follow-up. Okay, so we already kind of talked about that. So really knowing how you were exposed is kind of the key thing. Any questions with that? So that's a big thing I will tell you. Read that in your book. That is going to come up on your test. Ryan White Care Act. Tuberculosis compliance mandate. Am I going too fast, guys? I know I'm kind of talking fast. I'm going okay? Everybody's caught up with it? So tuberculosis compliance mandate. OSHA's respiratory standard. Selection and use of respirators. So OSHA has a set standard. It's on their webpage to find out what N95s are approved, what are not. You can't use a non-approved N95. So where a NIOSH approved N95, actually Russ, do you mind grabbing an N95?
Yep.
You should be right in that room.
Yeah.
You're left there. So on every N95 box, there is a NIOSH number if it is NIOSH approved. So this is a box of N95.
They obviously come in different sizes. You have to do fit tests for everyone, but there's lot numbers labeled on them and on the box.
Yep.
These are approved N95s by 3M.
And you'll see right on the side of the box, NIOSH approved. Okay? So when you do your fit test, you have to have the lot number for the N95 you use, and you have to have the NIOSH number. If there's no NIOSH number, it is not an OSHA approved N95. Okay? So wear a NIOSH approved N95 or HEPA mask when you are caring for patients suspected of having TB or COVID, transporting an individual from such a setting in a closed vehicle, in our ambulances, that is the most closed environment you can get in. So you are going to be up and personal with your patient, anything they have. Airborne wise, you are going to be exposed to. Ambulances do come with a filter. There's a button you can press and it actually pulls the air in through this filter, but there is still a risk that you can be exposed. It's not a permanent fix. Performing high-risk procedures such as endotracheal suctioning and intubation. So that is the most high-risk procedure we do when it comes to respiratory, because anything that is sitting down in their lungs is coming up. So anytime we're doing those invasive procedures like that, with you guys, you're going to be doing oropharyngeal airways, nasopharyngeal airways. You're going to be doing oral suctioning. That is all stuff that's going to put you at risk. Okay, so making sure you're wearing the proper equipment for all that stuff.
Even administering oral glucose too will put you
Yep.
at risk.
Absolutely, any oral medications, that all puts you at risk. So making sure you have the
EMTs
proper
do
equipment.
intubation? Or only-
EMTs do not. But if you're
Advanced.
working with a medic, or even an advanced EMT, you're right there with them.
Right,
So same thing, that'll put you at risk.
okay.
So making sure you get the proper stuff.
And you may be ventilating after the tube, and
Yep.
that still puts you at risk. So if
Absolutely.
you're ventilating, that's still.
So yeah, BVM ventilations, that's even nebulizer treatments.
Yep.
So if you're in the next to the patient, they're receiving a nebulizer treatment, that is like the most contagious way you can catch an airborne pathogen. So all those droplets are coming up and out and they're going right to you. So when COVID first hit, our protocols were actually adjusted that we were not to do any invasive airway procedures unless it was absolutely 100% necessary. So examples of that, we're doing like CPAP, nebulizer treatments, intubations. They were basically telling us, do not do any of that unless the patient's going to die. Okay? That since then has been kind of lightened up. We still have to perform the proper protective equipment if we're doing that stuff. That has not changed. So immunizations. Immunizations for hepatitis B, other infectious diseases should be available through your EMS agency. Any employer or EMS agency you go work for, they should ask for your immunization record and offer to you, if you don't have them, the proper vaccines. Regular TB testing may also be required. This is not a mandate by every agency, but it is something that's recommended. If you go to college, that's something that you have to get before you can attend. And this is something that was left up to agency and kind of system dependent on how they decide to go with it. Everybody good with that? So emotion and stress. So any questions about bloodborne, airborne pathogens? That fun stuff. Your book talks quite a bit about it. Today, if we have time, we will go through proper donning and doffing procedures with putting all your equipment on. Emotion and stress. All right, this is a big part of EMS. We do high-level calls in a very short period of time. So we're that occupation that goes from 0 to 100 really quick. That plays an effect on us. We go home every night, we see our family, everything we did that shift, we take home with us. So really knowing how to manage your stress, manage your emotions, is kind of a key part to your health. And the other thing is really looking out for each other. If you notice that your partner you're working with is having a bad day, they're not really handling themselves very well, talk to them, offer them help, do what you can for them. Okay? So emotion and stress. Physiologic aspects of stress. Stress is inevitable in this occupation. We vary to every type of call, whether it's an infant all the way up to our seniors. We see them in all different types and styles. Every call is different. You're never going to have the same call, and we're exposed to a lot in our career. So recognizing signs of stress and developing strategies to deal with that stress, that's important to our career. We're going to go over some different tactics to managing our stress. Resilience means toughness or an ability to overcome tough situations. So in our career, EMS is known to be resilient because we deal with a lot of stress on a day-to-day basis. This helps EMS providers deal with difficult situations. It includes an understanding stress, being physically and mentally able to respond, able to take care of our patients, and using different techniques to process difficult situations. All right? So we go to a scene, let's say a bus rolled over, right? A school bus rolled over. That, right out the gate, as soon as we hear the dispatch call, our mind is going 100 miles an hour. Our heart rate is high, our stress levels are high. You need to manage your stress on the way to a call. Russ put this perfectly a few nights ago. What you portray to your patient is going to reflect how your patient reacts. So if you're appearing stressed, you're anxious, you're fumbling, you're not knowing what to do, that's going to reflect on your patient, and your patient's going to be anxious, okay? The big thing about us is we're kind of like a duck. Above the water, we're calm, collected, we're being professional. Under the water, our legs are going 100 miles an hour, okay? So really, the biggest thing is just kind of maintaining yourself. After the call, doing a debriefing is really a good idea. Talking with your partner. Some services and hospitals offer stress debriefing. That's kind of a big thing that's coming about now, is mental health of first responders. So being resilient, managing your own emotions and stress. So the first stage of physical aspects of stress, alarm reaction. So fight or flight, all right? This is kind of our instinct, part of a natural response that we do. During an alarm reaction, we get toned to a call or we arrive on scene and it's a bad call. Our first reaction is our heart rate goes high, our senses kind of become in tuned. We're really trying to figure out the situation, manage the scene. During the second stage, we develop coping mechanisms. So we dealt with a stressful situation, and now we're trying to figure out how do we debrief from that? How do we take that home and deal with that? Okay? So we're trying to develop resistance to our day-to-day jobs. The third stage is exhaustion, loss of ability to resist or adapt to the stressor. So during the second stage, we're dealing with the situation in ourselves, having a hobby, talking with someone. If you need to see a therapist, talk to a coworker, talk to your boss or supervisor. Those are all different forms of coping mechanisms. If you deal with that internally, you don't talk to anybody about it, you hold it back, you go about your day and try to forget about it, that builds up, okay? And over time, that wears you down. You become exhausted, you lose your ability to adapt to stresses, and basically you're like a ticking time bomb. You're waiting for one small thing to just set you off, and that kind of ruins you for a little while, okay? So really kind of managing your stress levels, understanding these different stages, and looking out for this, looking out for your partner, looking out for coworkers, other providers, and then yourself as well. So different types of stress reactions. They may occur as a result of a critical incident. It can be one incident that affects you. It can be an accumulation of multiple incidents. Everybody's different.
I was just gonna ask, have you ever had a death on a call?
Me?
Yeah.
Oh yeah. Yeah. Lots of them.
We in one of the prisons I worked in Arizona, we had a cadet go down.
Yep.
We gave him CPR 28 minutes. I still remember it like it was yesterday,
Yep.
And then a month later, we had an inmate pass away. That one was really weird. It was like the inside. We saw it on the video. The inside of his body just kind of like went up like a balloon.
Yep.
And then just like it blew up. It was really weird. But anyways, like a series of events like that. I remember a lot of coworkers like, I don't care anymore.
Right.
They weren't coping with it the right way.
Right. Exactly. And it's tough.
It is. It was.
In this career, we're exposed to it a lot. So when we go to a call, with CPR in progress, the family members, bystanders on scene, they're stressed out to the max because they just witnessed somebody, whether it's a relative, close friend, or somebody even they don't know, they just literally just watch them die, right? And that's huge to them because they're not used to seeing that every day. I don't know, have you guys ever been to a cardiac arrest or Any of that stuff?
3 of us were there on Tuesday at one.
Okay,
Yeah.
so you've seen it then.
I had one.
You did have one?
Is that over?
And was it
Hannaford.
stressful? Was it
Hannaford parking lot.
thought so.
new to you? Yeah.
Yeah, my heart stopped.
Yeah.
I was revived.
Place just
The EMS saved my life.
Oh, no kidding. You were.
Well, I
Oh, you did?
I heard him to
No
the
kidding.
ambulance
Wow.
as they were leaving the station, they
Yep.
found fire.
Gotcha.
It's like,
Awesome.
I was very
Yep.
lucky.
We've had a couple,
Yeah.
We've had a couple of those.
That's it.
So I
Cardiac
called my
arrest.
I was like right in the parking lot too.
Yeah, I saw that.
Yep.
Everything just went
30
well.
more seconds, it would have been in the middle.
It's
of the
very
story.
unfortunate that
She hadn't
everything was
even gone
lined
in
up
yet.
to, oh no, she'd gone half
Oh,
of
did
it.
she?
Her AED was there. I
She
tried
went
to ask her to make it be nice for me.
Yep.
And,
Yeah.
it stopped in the end. Yeah, because it flew over and the CPR.
CPR.
She needed groceries.
I couldn't tell.
Yeah,
because
it's-
they
I
were-
was out for
Cardiac
maybe
arrest.
2 minutes.
How long
did you guys stay after I left?
Came
Oh,
to,
shit.
Yep.
I heard them
Yeah.
talking.
Yep.
And the one woman
Oh, no,
was
I went
like,
inside
that's
my
my
car,
first
like,
one.
I went inside my
car too. That's my sixth.
It actually stopped right
Sixth
away.
one, we got, he's like, out of there.
It
Your
was
heart stopped.
typically,
Oh,
PD won't
Yep.
make you stay.
Thank you.
Yep, absolutely.
Yeah.
Yep. So I
They,
mean,
they requested.
in this
that they
occupation, we see it quite a lot, unfortunately.
It's not a good
Cardiac
statistic.
arrest rates, if they're not
90%.
witnessed by EMS staff, survival rates are less than 4%.
Yeah.
So the biggest thing with cardiac arrest is early intervention, early
Yep.
CPR, early ventilation.
Quality CPR.
Exactly. And that's kind of something we're going to preach, is that BLS comes before ALS every day and all day.
I must have missed that lady by like 5 minutes max.
So he found her.
Oh, no kidding.
Yeah.
Wow.
Yep.
Yeah.
Right in the parking lot of Hannaford's. Right.
She was like 2 cars down from mine. I was walking out of the store and my mom saw her and like looks and she thought she was like dropped something or something.
Yep.
She was laying on her stomach. And I look over and I'm like, she's not fucking moving. I turn around, my mom's running. She's gone. So
Oh my God.
yeah, check for a
So she
pulse,
just
all
collapsed
that.
right there,
Called
must be.
AM care and
Yep.
she's like, can you turn her over and start
They call
compressions?
Enosburg.
Yeah, not
Okay.
AM care,
Not
you
AM
goober.
care.
Well, yeah. Either way.
Otherwise, she would have survived.
Damn. I've actually had a code without any ALS provider, and she walked out of the hospital
Yep.
twice.
Oh, wow.
Cardiac arrest, the biggest thing is BLS.
Yep.
We can give every drug that we carry on the ambulance, do every surgical, whatever intervention,
Yeah.
and we won't save them.
And to talk about stress, I was a brand new EMT, and I was the one guy in charge. That was a lot of stress,
Yep.
and you had to remain calm, and it was tough for me being brand new. But
Yep.
she walked out.
And you may come across that at some point in your career, that you're it. There's nobody else with you. You called for help and you're waiting for help to arrive, but they're relying on you. And that's a huge stressor on you. And really just kind of internally slowing yourself down and just saying, okay, what do I need to do? Well, they don't have a pulse. We're going to give them a pulse. Start CPR. If they're not breathing, we'll breathe for them. All right, back to basics. That's the biggest thing. You will at some point in your career come across a patient that is dying on you, and you have no idea what to do. All right, it's happened before. I've had it happen in my career, trying to figure out why this patient's dying, and while I'm trying to figure out, they're still dying. And it's really just going back to your basics. Okay. So, in the forms of stress, we talk about high-level stress calls. Good examples of that are cardiac arrest. We kind of become immune to them because we see them often enough. One personally that hits home to me is strokes. Another one would be pediatrics. Pediatrics would affect anybody. With pediatrics, all hospitals offer some form of debriefing. If we ever bring in a pediatric cardiac arrest to this hospital, we would have a huge debriefing with all personnel involved. With the EMS agency, if fire's there, fire will be debriefed. Hospital staff will be debriefed. And it's just really kind of a closure incident, making sure everybody's okay. That is a requirement by the state. It has to happen within 48 hours of the incident. Usually they kind of give you that 24-hour gap to really let yourself kind of take things in, and then you meet a little later on to go over that. But when you see it often enough, you kind of store it in the back of your mind and you don't really realize it until one day, everything just kind of hits you and you're like, what happened?
When you say pediatric, is that like 18 and lower? Is that 12 and younger?
Yeah, so
Like
usually
2 and
adolescents
younger?
and lower, so 16 and lower. You start getting into early adulthood
Yep.
after the age of 18. But yeah, it could be anybody. It doesn't even have to be pediatrics.
Well, no, you said that it was a requirement from the state for pediatrics.
Yes.
I didn't know where that threshold was for that.
Yeah, it's, I believe, I'm not positive on the exact age, but I believe it's 14 and lower.
Yeah, you were saying it, and I was like trying to think through the ones I'd been to and the ones that we didn't have one for, so I was trying to find that.
Yeah. Ever since, I think it's within the past year or 2 years, they've really kind of put this stress on mental health aid for first responders.
Yeah.
So that's why they're really starting to put this stuff in. They're doing it for law enforcement, they're doing it for fire, they're doing it for EMS, having these debriefings.
And that's whether you transport or not.
Yeah, it could be. So if you don't transport,
Yeah.
then internally your agency can reach out to VSP, and VSP will host a debriefing for you.
Gotcha.
There's actually a facility in central Vermont that's only for first responders in mental health.
Yep. So there's all types of resources out there. We have a list of resources in our files. I'll print that off for you guys so you can see the different resources available. There's actually an EMS suicide hotline, believe it or not, that's designated just to EMS personnel. So you can call the line if you're stressed or anything like that, and you can talk right to an individual, and they can get you the help you need. So a big thing to remember. So types of stress reactions, they may occur as a result of a critical incident, like I said, or it can be accumulation of things. Any situation that triggers a strong emotional response. So like we talked about, a cardiac arrest, any type of bad trauma, that kind of stuff. It can cause an acute reaction internally. And it doesn't even have to be an acute reaction, you first arrive on scene and you freak out. It can be, okay, the call's done and you lose it. That happens. It's part of our career. So an acute stress reaction, it's often linked to a catastrophe. Signs and symptoms develop soon after the incident. It affects physical, cognitive, emotional, and behavioral symptoms, normal reactions to extraordinary situations. It may require professional intervention. So it's never a bad thing to seek help, okay? Whether you want to keep it to yourself and seek help, or if you need to go to somebody and say, hey, I need help, but I don't know who to go to. Using your resources, that's what your supervisors are there for. Whoever's in charge, they have those resources available for you. So there are different types of acute stress reactions. Everybody's different. The way I handle one call may be different than the way you handle a call. Okay? It may be a simple call, it may be a really hard call, it doesn't matter. Any type of incident can cause an acute stress reaction. So looking out for those signs and symptoms are the big thing. If you notice somebody is really anxious, or the opposite, they can become really depressed and reserved. They're not acting themselves, they're not talking to you, they're staying away from everybody. You go to another call after your severe incident and you notice that they're arguing with the patient or they're acting inappropriate. Keeping an eye out for those things and saying, hey, let's get another crew here and sit this one out because I'm noticing that you're having a rough time from our previous incident, or anything like that. So that's an acute stress reaction, and then we have a delayed stress reaction. So PTSD is a form of delayed stress reaction. Signs and symptoms are not evident until long after the incident. Delay makes dealing with the reaction much harder. Patient may not recognize what is causing the problem. And this requires intervention by mental health professionals. Okay. The thing I'll say about this, so in the EMS field, we're just expected to do our jobs and nothing should affect us because this is what we signed up for, right? That's not what this is about, okay? Any type of call can affect any individual differently, all right? Even if it's a simple ankle fracture that really bothered you. Sometimes the accumulation of this type of stuff can trigger a reaction because you're holding it all in, and you can actually develop PTSD in this field. You go to a bad car accident where, let's say, a mother and child died, right? That stuff can sit with you long term. And when you're at home with your children and you start showing signs and symptoms, you start getting angry with them for no reason at all, you know, that can be a sign that you're holding in these different stressors. So again, signs and symptoms may not be evident until long after the incident. Really seeking professional help is the big thing. Talking with a clinician, talking with your primary care doctor, or seeking a therapist, those are all good things to help you manage this. And even with patients, often enough we go to patients with PTSD, whether they're former military or you know they had traumatic events as a child, any of that type of stuff. They may not know what's causing their symptoms, and it could be from a form of PTSD. We're not going to diagnose PTSD in the field, but we're looking for it. Okay. A cumulative stress reaction, so burnout, results from years of sustained low-level stressors. Early signs include vague anxiety, boredom and apathy, and emotional exhaustion, right? So in this field, do we experience burnout? Absolutely, 100%. The burnout rate for FDNY is 1 year. 1 year. That's what their rotation is. I mean, they experience the highest level of calls of any EMS agency in the entire country. But their turnaround rate for EMS providers is 1 year. And that's just because you're serving one call right after the next. You see a lot. You know, some people don't experience burnout until 10 years into their career. It's not to say that it happens to everyone, but it's something to look for. And it results from years of sustained low-level stressors. So if you grew up with low-level stressors and now you decide to go into this career and you're experiencing high levels of stress for years on end, you know, you're not in tune to coping with it or knowing how to deal with it. So again, early signs are vague anxiety, boredom, and apathy. So you know somebody's not being sympathetic towards their patients, and emotional exhaustion. Progress to physical complaints, loss of emotional control, irritability, and depression. So they're appearing very apathetic. You know, they're reserved. They're not talking with anybody. They're irritable to small things. Those are all signs of cumulative stress reactions. And it may present as a severe withdrawal or suicidal thoughts requiring long-term psychological intervention. So different causes of stress. An MCI incident can definitely cause stress. You know, that's one of those calls that we dread in our career. Does everybody know what an MCI is? So mass casualty? Yep, exactly. An example of that would be
9/11.
Well, your bus
9/11.
the bus roller you mentioned.
Yep, exactly.
You've
So
a car accident with 2 or 3 people.
what deems an MCI? At what point do we say this is considered an MCI?
Is it 3 or more?
Three or more what?
Is it 3 or more patients?
Not necessarily.
More than your unit can handle.
More than the resources available to that call, right? So a 3-car MBA, we've got 5 patients and I've got 1 EMS going to that, 1 EMS unit, right? To that situation, that's considered an MCI because that is above the resources available to that incident. Now, until we get enough ambulances there and enough providers to manage all the patients, we're treating it as an MCI. Exactly. You know?
You remember a few years back, this happened in California, there was like 2 busloads of students that were going to up north, NorCal, and I don't know what happened, they hit something or whatever, but one of the buses caught on fire, and a lot of those students got killed.
I don't remember that.
Yeah, it was up in Northern California about 4 or 5 years back. An EMT class I was taking, we had, there was an instructor there who was there, and he was telling us that when the bus, when they took everybody off the bus and all that, that they know that when they were doing the autopsies on the bodies and all that, a lot of them had they were crushed. I guess my question is, what would that be called if it was just like one incident but a bunch of people, and that bus and all that, and with all the students?
That could still be deemed as an MCI.
Okay.
Absolutely. If it's exhausting or above the resources available to that incident, then we consider it an MCI.
Multiple casualties?
Yep. It doesn't even have to be casualties, it's just you have more patients or more things to deal with than what's available to you. So I mean, it can range from 9/11 to a 3-car pileup, and we've only got one ambulance going to the call.
Like the one they had in Richmond the other day, that
Yep.
bus, that was considered an MCI.
Yep. So they do happen from time to time. It's not very often in our career. Usually in bigger kind of metro areas, it's more common. In my career, I've only had one considered MCI situation, and it was resolved within 20 minutes of that call. It was a 3-car pileup with 5 patients, and I was the only unit there. So kind of like what Greg was saying, we go into our training, and we're going to cover MCIs with you guys, how to manage them, but it's doing triage. Going to your BLS, are they awake? Are they able to walk? Are they breathing? Do they have a pulse? Just really trying to figure out who is the most critical and who can wait a minute. Okay?
Would you treat something if you had, like you said, a 3-car accident and you come to the scene, yourself, your partner, 3-car accident, 6 or 7 people there, they're all gone.
And they're all gone?
They're all gone.
So from that point, so you have no patients, it's basically
So it's not
everybody's
an
gone.
MCI, it's just a tragic situation.
Yeah, then you go to a debriefing. Yeah. Yeah, that's a traumatic incident. You don't have any patients. It's really just working with law enforcement to figure out what happened and then doing a debriefing afterwards, kind of preserving the scene. So, again, MCIs can be a cause of stress. Calls involving infants or children, definitely. Severe injuries, so gross injuries that we come across. You're going to see all kinds of traumatic incidents. You're going to see bones sticking out. You're going to see internal organs, that kind of stuff. Things that you don't normally see in the public, obviously. Those are all stuff that, right, that's all stuff that we kind of hold internally. And it's something that we remember later on. I've been doing this EMS career for 11 years, almost 12 years now. And I can still remember those major incidents, those traumatic incidents that I've come across. There's things I will never forget. So severe injuries, abuse and neglect. This is one of our requirements when we take this job. Once we get our license, we're the voice of the patient. So if we're suspecting abuse or neglect, we're the advocate for the patient. We're doing what's needed, whether it's filing a DCF report, filing an APS report. All that stuff is part of our job. And that, again, can affect us. If you come to take care of a pediatric who's being abused, internally that's going to affect us. And then death of a coworker, definitely. Somebody you know, somebody you're close to, or somebody you work with, that can definitely affect you. So signs and symptoms of stress. Eustress. Positive form of stress that helps people work under pressure and respond effectively. So you have eustress and then distress. Distress is a negative stress causing immediate and long-term problems with health and well-being. So eustress is a positive form of stress. Distress is a negative form of stress.
Positive form of stress.
Positive
Give
form
an
of stress.
example.
So a positive form of stress that helps people work under pressure and respond effectively. So a good example of that is positive feedback. Like, it's not to say that it's a bad thing, but we're working at cardiac arrest and the person I'm working with is saying, hey, you're doing great compressions, good job with that, good feedback, that kind of stuff. Internally, we're always trying to fix things that we want to do better ourselves in our career. So if we're just getting continuous positive feedback, that's going to stress me out to be like, okay, am I just amazing at my job? Am I doing everything perfect? That can wear you down as well. So it's good to get negative feedback and positive feedback on what you're doing. Any questions on that stuff? So eustress positive, distress negative. Irritability, inability to concentrate, changes in daily activity, anxiety, definitely, indecisiveness, guilt, isolation, loss of interest in work. So these are all kind of depressive stages. These are things to look for within ourselves, to look for within our coworkers. You know, if you're becoming irritable, you're not able to concentrate on things, you're changing your daily activities, you don't want to do the things you normally do. You could be sitting at home watching TV and you feel anxious and you don't know why. It can be internal stress that's affecting you. And these are all things to watch for. It's not to say you guys are going to develop this first thing out of the gate. These are just things to be aware of. The National Registry doesn't test you so much on this. You will have a few questions on what is stress, what are signs and symptoms of stress, and maybe even the different types of stress. Okay. So let's think about it. If your partner is beginning to show signs of stress, what should you do?
Talk to them.
Talk to them. What else can we do for them?
Give them help if they need it.
Get help for them. Ask them, do you want help? You know, if you don't want to talk to me, is there somebody you can talk to? You know, as supervisors, we try to watch over our employees closely. And if we notice that somebody's not doing well, they're not managing their stress well, they need to take a day off, or they need to go seek mental health or something like that, we'll offer that to them. And you know, we can't be watching everybody at all times, so we really rely on their partners to come to us as well. So that's good, talking to them, offering them resources. What possible risk could be there? What possible risk could there be to your partner, you, or a patient if stress is left unresolved?
Mistakes.
Mistakes. What kind of mistakes?
Patient assessment, everything from top to
Missing
bottom. Anything can
assessments.
happen. Yes.
Yep.
You're not focused.
Medications. You know, all that stuff can affect your patient. What were you gonna say, one?
Oh, I was just gonna say the situation could go bad.
Right. Absolutely. If stress is left unresolved and your partner just randomly starts yelling at the patient for no reason, that doesn't help you. That doesn't help your patient, and it definitely doesn't help your partner. Okay. So, debriefings are important. After a bad call, talking with your partner, talking amongst, that's the first thing we do basically after every call. We talk about how it went, what could have gone better, and you know, really kind of debriefing ourselves with every call. Do you have an obligation to act to help your partner?
Yes.
Why do you have an obligation?
Because trust, communication, all that. You guys have to depend on each other.
Mm-hmm. Absolutely.
And the patient.
Right?
Yeah, I mean,
If you
it's,
two aren't doing your job together well, it could affect the patient.
Absolutely. Patient outcomes, performing assessments, performing treatments.
then not to mention the perception of, you know, just say like, I show up and I'm like in a pissed off mood, and I'm with this gentleman right here and he's all happy, and I'm with the patient. Guess what? I mean, we did a lot of you talk about, we did this in corrections too, and
Mhm.
like you would always hear, man, don't talk to that CO because he's this or that and he doesn't care and all that stuff, and it's just like,
Yeah. And you may come across that situation where your partner isn't helping the situation with a patient, and it's like, hey, I'll take this call. Why don't you kind of sit back? If you need to get another unit there to take the call from you, do what you have to do. But basically, if you notice your partner is acting, you know, outright or whatever, you know, pull them from that situation because it's just going to get worse, right? So, supporting each other, that's what we do in this job. Dealing with stress. Lifestyle changes, develop more healthful and positive dietary habits, exercise, devoting time to relaxing, change shift or location for lighter call volume, different call types, and more family time. So lifestyle changes and critical incident stress management can help EMTs overcome work-related stress. So kind of the big thing with this, if you just let everything internally build up, at some point you're going to develop cumulative stress disorder, or you can have an acute stress reaction. So having either a hobby, having some form of outlet, a positive form of outlet I should say, those are all good things, and that's why exercising is important. devoting time to relaxing. If you work 24/7, 365 days a week, you don't have the time to really debrief, take yourself away, and allow your mind to reset. So, kind of the last point here, change shift to location for lighter call volume. So with us, we have the city, which is our busier station, and then we have Sheldon. We try to rotate everybody at least every 2 weeks to go to the Sheldon station. Not to say that you won't get calls there, but your call volume is much less there. So that's something we try to do here. So that way everybody gets at least some time to reset their mind.
It probably goes the other way too. If you have a crew that's up there all the time, they get bored, they lose their skills,
Right,
etc.
exactly. Yep, absolutely. That's why it's good to rotate. Some services don't have multiple stations. Sometimes if you're working in a metro area, and it's just every time you go on shift, you work 100 calls a day. You know, at some point you're going to want to say, hey, I need to take a break from this. I'm going to go to a lower call volume agency to allow my time to reset. So dealing with stress again, invisible wounds, preventing psychological trauma. Psychological trauma can result from tragic scenes. A system that takes in stimulus from a traumatic incident may malfunction. So, list me some stressors related to your job performance as an EMT. What are some stressors that are part of your job as an EMT?
Dealing with
Trauma, massive trauma.
Massive trauma.
Patients in pain, watching them in writhing in pain.
Yep.
Dealing with the family.
Yeah, that's a big one. Absolutely. Whenever we go to a pediatric call, we always say there's two patients. The child and then the child's parents.
Odd hours.
Odd hours? Absolutely.
Dealing with the same patient over and over and over.
Yes, yep. And you can become complacent with those patients. That's a big thing to remember. You go to the same patient, 10 times in one day, and it's like, oh, we got to go back there again. They're fine, let's just sign them off and get out of here. Well, that's where lawsuits get involved, and that's where you miss something.
Because it's the one time that you do that, but something's actually wrong.
Absolutely. Yep.
Yeah.
And you will have your frequent flyers in your career. We still treat them the same, even if it's the 10th time we've been to them that night. We haven't slept a wink, and we're still going to them. We're still keeping our composure. We're still being professional, and we're offering them the help that they need. Were you going to say something?
No.
So yeah, those are all great examples. So invisible wounds again. We're trying to prevent psychological trauma. So the acronym ESCAPE. So E, every patient, social support, choice and control, anticipation, planning and organizing, and every time. All right. So this is one form of preventing psychological trauma. You won't really be tested on this in your book, just the basic acronym itself. There's different forms of acronyms for this. But every patient we go to, we're apathetic for, or sympathetic for. Having social support for yourself, using resources that are available, making good choices and having control of your situation and your scene, anticipating what's going to happen with your patient. So if we go to a really sick patient, trying to be ahead of the game. If you go to a car accident on the road, anticipating that I need to fire to block off traffic to prevent a dangerous situation to the scene. Planning and organizing, and then performing this every time. So critical incident stress management. This is kind of that debriefing that we were talking about originally. It's a comprehensive system. VSP offers this for EMS up here in the North Country. It includes education and resources to prevent stress and ways to deal with stress appropriately when it occurs. So these debriefings, I've been a part of 2 of them in my career. Patients that you transport to the hospital will perform a debriefing. Or if the hospital doesn't perform one, then you can get VSP involved and they'll offer it for you. So CISD, it's designed to help diffuse, first responders diffuse after an incident. So the individuals are trained, they're peer counselors and mental health professionals, and they meet with you and healthcare providers involved in major incidents 24 to 72 hours after the incident. So like I said, that time frame, they give you 24 hours to really kind of internally debrief, and then collectively you meet with the other individuals involved to discuss the situation. So it helps responders deal with the stress. Understanding reactions to death and dying. So we're going to spend the whole subject on this. That's part of our career. We're going to deal with patients who are on hospice care. They're on end-of-life care, they're dying, or a patient did die and we need to be a support to the family. So the different stages to death and dying: denial, or it's not me. So somebody gets diagnosed with a terminal illness. The initial kind of reaction is, there's no way this could happen to me. Then, after that comes anger, trying to come up with a solution as to why did this happen to me. Bargaining, which is, okay, but first let me do this, right? So it's trying to get things done that you didn't have the chance to do, and you're trying to bargain for your life, not necessarily your life, but the patient's life. Depression, or okay, but I haven't. So this is the depressive phase. Basically, they're starting to understand that they're dying from this illness and figuring out the things that they didn't get the chance to do. And then the last part, the last stage, is acceptance. And it's okay, I'm not afraid. So you're going to deal with patients in every single one of these different stages. And it's really, if they're in the anger phase, don't take it personal. They're not angry with you. You know, if they were diagnosed with a terminal illness and they're in this stage where they don't understand why they have this terminal illness, and they're taking their anger out on, you know, whoever is there. So, kind of part of our job. This can be stressful on us. You know, especially if it's a relative of ours, a close friend, anything like that. This internally affects us, and we're going to go over how to deal with each of these phases a little later on. So understanding reactions to death and dying, recognizing the patient's needs, be tolerant of angry reactions from the patient or family members. So be empathetic, be sympathetic, listen with empathy. Don't try and talk over them. Just let them vent to you. You're a set of ears. And let them say what they need to say. Do not falsely reassure. All right, this is a big one. What does that mean?
Don't tell them everything's going to be fine when they know it's not going to be fine. It's
Absolutely.
patronizing.
Yep.
Don't tell them they're gonna be fine when their neck's half cut off.
Right.
Don't lie to them.
Don't lie to your patient. You know, you're taking care of a patient, you have a family member there, and you're performing CPR. Don't tell the family member that
They're gonna be okay.
right. Exactly. You know, the reaction to that is, we're doing everything we can, and we're trying to support them the best we can. You know, a lot of the times family is frustrated with you because they called you to help their loved one. You know, I did what I'm supposed to. I called 911. You know, my friend went into cardiac arrest, and you're supposed to save them, and you didn't do that. Why didn't you do that? We don't save everybody, right? 4%. So don't give false reassurance, okay? Offer as much comfort as you realistically can, okay? Everybody kind of reacts to stress differently. Some people are reserved, they don't want to talk to you, and if they don't want to talk to you, you know, in that moment in time, give them space. Allow them to kind of internally debrief what they just went through, okay? Again, everybody's different, and just deal with the situation as it is, be a set of ears. really listen to them. Let's take a quick 10-minute break, and we'll go over scene safety discussion and scene safety. So the big component of tonight, I'm sorry, I know it's kind of redundant and maybe a little boring. All important stuff though. So tonight's major focus was well-being of EMS, so scene safety, BSI. Say that 100 times every day because that's the first thing you need to say when you walk into your psychomotor. All right? So we're going to talk about scene safety. So scene safety. EMS is not usually a dangerous profession. Yeah, right. Being aware of potential dangers is always a priority. So give me an example of a danger on a scene.
You've got leaking petroleum in a wreck, and you're trying to tend to your patient, and something sparks it off, and you're all going home.
Absolutely.
You have an emotionally unstable patient or another person on a scene.
Yep.
That happens a lot.
Dark. Just being nighttime. We can't see everything.
People can't see you.
Yeah.
Even think about it, cardiac arrest, family members are freaking out, telling you to save them, sometimes they get aggressive.
Then you got the old standby, right middle of the night, you gotta sit there and deal with a junkie.
Yep.
And it's like, the EMS couldn't handle it, so we're gonna handle it.
Exactly. So consider every situation we're involved in. Consider what could happen during that situation. We go to an accident on the interstate. The interstate is the most dangerous call we go to in our career. So having a fire truck that's stopping traffic or protecting you behind you while you're managing a scene, whether you have to shut down the road or not. Those are where a lot of fatalities come from in our profession. Road incidents, dealing with unstable patients, patients who may be on PCP, patients who are having acute stress reaction, patients with mental illness. Those are all examples where we could be harmed by the patient. So maintaining your safety, maintaining your partner's safety is priority one, okay? And then it comes to protecting the patient, okay? You can't help the patient if you're hurt, all right? So if you need to call law enforcement for support, if you need to call fire for support, or you need to call another EMS unit to come help you. So being aware of potential dangers, determining scene safety will be the most important decision on every call you go on. So that is our number one priority to every call we go to, is the scene safe. I wouldn't say every mental illness call we go to, but any type of suicidal, homicidal call we go to, PD goes on scene first. We are not first on scene. Don't enter a scene first. If you're going to a suicidal patient, wait till PD gets there. They will clear the scene, and then we can go in.
Okay. If you go on scene 2 and it gets violent, you can always go outside into your vehicle and wait for VSP
Back
or somebody to arrive.
Yep.
You don't have to stay in the...
You're not abandoning the patient. You're not, nope, we're done, we're leaving. This is PD's issue. We're pulling ourselves back because the situation's unsafe. We'll wait for PD to arrive, calm the situation down, making sure we're safe, okay? So the primary rule is to maintain a safe distance from the source of the hazardous material. So if we get into hazmat, there are placards. Ensure that your emergency vehicle is equipped with binoculars. That is a standard that's required on all ambulances. Correspond with coded colors and identification numbers that are listed in the emergency response guidebook. Actually, Russ, I'm doing me a favor.
Yeah, I'll go grab an ERG. Also, the ERG app works really well too. The app is phenomenal, but all of our trucks have ERGs. I'll go grab them.
Required you by law.
Required by law. I believe every fire truck has to have one too, right?
And every police car.
So that way, if there's a hazardous incident, you can recognize what the material is. So Russ is going to go grab that book if you guys haven't seen it
If you
before.
don't have them, you can just call the number. They send them for free.
We all have the apps anyway.
Yeah.
We have the books too.
Yeah, every first response apparatus has to have that book, and that's for our safety. So while Russ is grabbing that, so this is covering hazardous materials. Our role is recognizing the potential problem, take actions for personal safety and the safety of others, notify a trained hazardous material response team, and do not treat patients until after they have undergone decontamination. That is a big one. If you're involved in an MCI, there's factories in pretty much every town. There's hazardous material in those factories. It needs to, if there's an exposure, it needs to be identified what is the exposure, what are the risks, and then you need to put yourself in a safe situation.
And these go in depth on what you have to do for responses.
Yep.
But
So these are the new ones, 2020. They come out every,
hey,
I believe it's every 4 years.
we do not en route to UBM. Thanks, bye.
These are the books that are on every apparatus. It can be identified with color-coded placards. There's different colors, different pages to help you kind of point out really quick what the material is. Okay? So part of AmCare's requirement, everybody has to be certified to the hazmat awareness level. Then it goes up from there to hazmat responders.
Operation, then technician.
Operation, yeah. So we're at the hazmat awareness level. So, using binoculars to identify hazardous materials before approaching an emergency site. So if we go to a factory that a gas is being spewed from a tank, don't know what tank, don't know what the type of gas is or anything like that, looking from a safe distance to try and identify what the material is. Terrorist incidents, maybe small or in large scale. What's an example of a small scale terrorist incident? We had this 15 years ago.
Like a school shooting? Is that small or no?
That could be small scale. How about biological?
What do we have?
It was submitted through the mail.
Oh,
Anthrax.
Anthrax, right? So it can be small scale, it can be large scale. It may include chemical agents, biological agents, radiation, weapons, explosive devices. They can range through any one of those. So rescue operations, you're rescuing or disentangling victims from fires, auto collisions, explosions, electrocutions, and more. Before we do any of that, we're ensuring our safety, okay? If we go to a scene where we're trying to pull a patient from a vehicle that's teetering on the edge of a cliff or whatever, we're not going to enter that vehicle until we know that vehicle is secure. And that even goes for if the airbags haven't gone off, that's fire's point to make sure that the batteries are off or the lines are cut so the airbags won't go off while we're in the vehicle. Okay? Evaluate each situation and ensure that appropriate assistance is requested early in the call. If we go to an MVC, we want to make sure fire's on their way, police are on their way. If you go to a fire call, obviously making sure that fire's on their way, but whatever resources you need, call for it, call it early. What is an example of something we may request in the field?
Helicopter.
Helicopter. Absolutely. Don't ever be afraid to call for the helicopter. Okay? We're kind of reserved on calling for the helicopter because we're so close to the hospital here. However, the helicopter, right. The helicopter is a great resource, okay? Patients who are severely sick, traumatic incident, or whatever it may be, they can get the patient to a level 1 trauma center much faster than we can, okay? So that is a resource that is available to us. Now that UVM has a helicopter, it's much closer to us. Never perform acts that you are not properly trained for. All right, so in this career, if you're working as an EMT, at least here we have multiple firefighters who work for us as well. When they're on shift with us, they're on shift as an EMT or whatever their cert level is. They're not on as a firefighter. So they can't just jump off the ambulance, run and grab a hose and go put out a fire. Okay? Yeah, wishful.
Did you guys ever like run a pump though to help for a few minutes? You don't do anything?
We're there for any patients that may develop. Because if we get pulled, if my partner gets pulled and he's working with fire, and I have 2 patients that come to me that are severely injured, now I got to go find my partner, figure out where he's at, bring him to help me out.
The only thing I've ever done was tag the hydrant, and the ambulance is right there, and my crew is right there.
Yeah. But,
Right. So our
I mean, that's
priority.
kind of generally what I was saying. It's like
Yeah.
something that you're not really
Right, as
Being
long as you
totally
keep in
tied
mind
up
that's
on-
your priority. If you're on the ambulance, your priority is to take care of patients.
Yeah.
That's the big thing with that. So don't ever perform any acts that you're not trained to do, because then you can be detrimental to other individuals or bystanders at the scene.
I mean, like when St. Albans cops always go into burning buildings before fire gets
Yeah,
there?
we don't suggest that.
Yeah.
Be snipey.
Good point, but we don't suggest that. So, the realities of well-being. In some situations, you will have to make calculated decisions between helping or personal safety. There is a point, hopefully you never come across it in your career, but you may have to make the decision, is it my life or theirs, right? You can't do any help if you're hurt, right? So, making good calculated decisions, making safe decisions, making sure your safety's in mind, your partner's safety's in mind, and the patient's safety's in mind. Know that despite your best efforts, some patients will die. That's part of our career. We can't save everybody as much as we try. As much knowledge as we have, patients do die. It's a natural part of life. So understanding that scene safety and well-being are determined by the decisions you make under pressure. So we roll up on a scene, you've got 3 unresponsive victims in a car. The first thing we want to do is we want to jump in the car and start helping. Well, if that car is a risk to ourselves, it doesn't do any benefit if we get hurt trying to pull somebody out. So wait for your safety, wait for available resources, and then help the patients from there. Violence. So the first thing to violence, planning, preparing, knowing your way out. Any house we go into, I know where the exits are as soon as I enter that house. Okay? Especially if we go to domestic violence situations, if we go to suicidal situations, homicidal situations, always knowing your exit strategy. Okay? Wear safe clothing, prepare your equipment so it's not cumbersome, carry a portable radio whenever possible, and decide on safety rules. Alright? So the key feature to all of us is our eyes, observing what could be a safety hazard. Your partner is also looking to see what could be a safety hazard, planning to understand, what are the potential hazards around that scene. That's really where teamwork is involved, because I may not recognize a hazard and my partner might see it. So that's where you have to work as a team. Observation, survey the scene on approach. So as you go through your psychomotor exam, you say scene safety BSI. If you don't say that, and we're going to run you through this, if the first thing you do, you say, I'm wearing appropriate BSI, I enter the scene, well, we may throw at you, oh, there was a gunman that was standing behind the tree there, and you didn't clear the scene before entering, okay? Keeping your safety in mind. Do not announce arrival, turn off lights and sirens. Okay, we're not trying to attract other outsiders or observers to our situation, right? We're trying to preserve the scene. We're trying to preserve the patient's dignity, their identity, all that stuff. So if you go into an urban area, you go into a dangerous area or whatever, you're not trying to promote others to come towards you. And you can do that if you leave your lights and siren on while you're in a house, right? So observation, observing violence, understanding crime scenes, alcohol or drug use, different weapons that are on scene. So if you see violence, if the patient says to you, my boyfriend hit me or whatever, and that boyfriend is still there standing next to the patient, or you notice that the patient isn't being forthcoming with you, and it's because another individual's in the room and is abusing them, pulling them away from their abuser, protecting them, protecting yourself. Crime scenes. At some point in your career, you're going to be involved in a crime scene, really kind of preserving the crime scene. We typically, if we go to a crime scene, we kind of limit who goes into the scene to take care of the individual. We kind of have an understanding that the way you walk in is the way you walk out. Okay? Alcohol or drug use. Alcohol and drugs can impair patients' cognitive function. So depending what drug they took, if it was cocaine, cocaine is an accelerant that can make them really anxious, that can make them combative. Same with PCP. Alcohol is a depressant. A lot of times alcohol will cause people to be depressed. They may harm themselves. They may have suicidal thoughts. Weapons, always identify weapons on scene. If you see a gun sitting on the counter and you're talking with your patient, they're saying they're suicidal. While I'm talking with my patient, I may have PD or my partner, put it into a safe location where we're not going to get hurt. Somebody from around the corner isn't going to grab it and shoot at us or anything like that. Family members. Family members, a lot of times, they're anxious, they're upset. Your focus is dealing with the patient. If you need to call an extra crew, to be kind of a support for the family while you're trying to take care of the patient, do what you have to do if you have available resources for it. And then bystanders. This is a big one. So with bystanders, I'll give you an example. A lot of times we have bars down on Kingman Street and stuff, and a lot of times we go to Kingman and somebody's laying on the sidewalk unresponsive. Well, prior to COVID, there's a lot of people at the bars, and the first thing they all want to do is come out and see what's going on, right? So you're trying to clear the scene, preserve the patient, preserve their identity and stuff, and call in resources. We use PD a lot to say, hey, can you get everybody back? Dissipate the situation so that way you can take care of the patient, and you don't want some random bystander coming up and harming you. Perpetrators and pets. Pets, I've never had an issue with pets. We do ask when we go on scene, if they have an aggressive dog or any animal for that matter, we ask them to put their pet away so that way we can take care of them. If they are unable to put their pet away, then the animal control can come and help you out with that. We have used them from time to time. So as a safety precaution, do not stand directly in front of a door when knocking or ringing the bell. You never know. Somebody could be standing on the other side of that door waiting to stab you or shoot you. So typically, we don't do this with every call, but it is a good habit if you're knocking on a patient's door to stand to the side of the door. As soon as you enter their house, look around the corners. A lot of times, like you said, if it's dark out, we can't see everything. So using a flashlight to really identify, okay, where are my exits? Are there any safety hazards in here that I need to be aware of?
A couple of years ago up on Diamond Street, there was a St. Albans cop and welfare worker that knocked on the door and met with a gunshot from the other side.
Yep.
And the glass actually cut the officer. So
Yep. They were just going to
got
check
really
on
lucky.
somebody,
Yep.
and they got super lucky.
Yep.
Announce your presence loudly,
Yep.
who you are.
Yep, exactly.
Okay.
Especially patients who are hard of hearing or dementia. You walk up to them and they're saying, who are you? Are you in my house? They may go belligerent. Or a lot of times third-party calls. Anybody ever heard of third party?
We've had a couple of those.
Yep.
We have no idea why they're there.
Yep. We get third-party calls a lot for suicidal patients. They were on the phone with someone and said they wanted to harm themselves. Well, that individual then calls 911 and says, hey, you need to go to their house because they're telling me they're going to hurt themselves. That's dangerous for us because that individual may not know that we're coming.
They may not want you there.
Right, exactly. So using PD to make sure the scene is safe before entering. React to danger. The 3 R's. Respond, radio, reevaluate. Do not re-enter a scene until it has been secured by police. Okay? So if we're going into a dangerous scene, we're responding. We typically will stand by, wait for PD to enter the scene, and then clear us. When we stand by, depending where it is, we may stand by at our station. We may stand by a block away from the scene. The biggest thing is when you stand by, you want to stand by so you're not visual to where the scene is. Okay? And then radio, you're communicating with dispatch, you're communicating with your other ambulances, letting them know where you are. Radio is a huge tool if you get in a tough situation, somebody's trying to harm you. you're radioing to central, I need help, whether it's for another ambulance or for PD or whomever. And then reevaluate. Reevaluate the situation. If you need to back out of the scene, then back out. Your safety comes first. So reacting to danger. Never enter a scene that is potentially violent until the police have secured it and told you it is safe. So it is not our job to subdue a patient and secure the scene. That is their job. We're not trained to do it. We're not equipped to do it. So we're not going to go enter a scene or a patient who committed a violent crime, subdue them, and then take care of the patient. Right? That's not our job. That's what PD's for. Okay? So wait for PD to clear you. Once they've cleared you, you can enter the scene. Another reaction to danger, if you do come across that situation, your patient appears totally normal, they seem fine, you get in the back of the ambulance and then all of a sudden they flip on you. We've had that plenty of times. What do? You're rolling down the road, it's just you, your partner's driving, and you've got the patient who's now trying to harm you. Number one, stop the ambulance. If you need to get out, get out. If your patient's telling you that they're going to harm you unless you let them out, then you pull over safely.
Let them out.
Depends on the situation.
Well, if
you
they
need
say
to let
they
them
want
out,
to get out, you have to legally pull
let them
over
out.
safely.
You try not to
let
put
them
them into a situation where they're going to go harm somebody else, but it's kind of a judgment call on that. But the biggest thing is maintaining your safety. If you need to get out of the back of the ambulance, then pull over, get out of the back of the ambulance. Okay? Get rid of any cumbersome equipment. So what would be some equipment that we carry that the patient could use to harm us?
Oxygen.
Oxygen, absolutely.
That raptor on your side?
Yep. Anytime we go to the prison, we have to take off any sharp objects, pens, scissors, cell phones, all that stuff. We have to get rid of it before we can enter the prison. So, a good thing to keep in mind. Everything should be secured behind a cabinet, closed doors, whatever. Making sure you're not giving that stuff, that access to the patient. Take cover and conceal yourself. So, if you're in a situation where suddenly you're being shot at, number one is take cover. Get behind something large. In our ambulances, the best place for your safety is behind the engine block. All right? Typically in the back of the ambulance is a safe spot, depending if they're shooting at you with armor-penetrating bullets or whatever. But the biggest thing, if you can't quickly leave the scene, take cover, get behind something. And then the other thing with that is conceal yourself. Don't announce yourself where you are if you're being shot at or sought after. Concealing yourself is placing your body behind an object that can hide you from view. So whether it's behind a tree, behind your ambulance, behind a building, wherever. Alright, so that's pretty much it for Scene Safety BSI. Do you guys want to go through the chapter review or go over anything that didn't make sense? Any questions? Your book goes into a lot more detail on this. With our time remaining, what I would like to do is just go through some of our safety equipment with you guys.
I got a scenario I want to ask about.
Go for it.
So, you get a call for self-inflicted gunshot wound, patient's unresponsive, family members there attempting to start CPR. Is it appropriate to respond? Or are you going to wait for
It's
law
appropriate
enforcement
to respond, but stand by.
I went on one of those in Enosburg, on one of my ride-alongs in Richford, and we had to wait until, Border Patrol arrived, because we didn't have VSP, but Border Patrol arrived, and that was...
Because the biggest thing is just there's so many unknowns to it. You're told that the patient shot themselves, but you don't know if somebody else shot them. So until PD gets there and really clears what happened, we're not entering until they clear it. That's a good question, though. Absolutely. So give me a minute here. Russ and I are going to collect some PPE and stuff to go over with you guys.
We are?
Yeah. And you're going to be the mannequin.
I was just gonna ask, does EMS personnel out here get active shooter training?
We went through an active shooter training in 2018.
But not like a once a year thing?
Now, since COVID hit, we haven't been able to do repeat trainings.
We do carry bulletproof vests and tactical EMS bags and ready for an active shooter situation.
Yeah, so
Level.
What's that?
What level did you go?
Oh boy, I have my TCCC cert.
For active shooter?
Yeah.
Tactical stuff.
Yeah, it's more the tactical side of things. But we also did, I forget the official title of it. It was basically, what was it called, Russ? I don't remember.
I have no idea.
Was it the Alice training?
What's that?
Was it the Alice training?
Owls
Shooter?
Alice. Like Alice in Wonderland.
No. No, we were actually trained with the local law enforcement and the tactical team too. And basically, in our situation with that, we were treating it as like an active shooter situation with multiple casualties or individuals. It's a really cool training. I highly suggest you guys do it.
And we actually do train with all first responder agencies here quite often. We train with PD, fire, almost once a year.
Yes.
So we do train a lot with them.
Yeah, COVID's kind of put a damper on that stuff, but we're going to start doing it again.
Damn.
How about across the, you guys ever trained with like New York, New Hampshire, Massachusetts or anything?
No.
No. Not here. Their protocols are really different from ours. I guess there could be an incident where we have to go respond like an MCI, and they're calling for multiple agencies. There's actually one, 9/11. Swan Fire sent a truck down for 9/11.
Oh, wow.
Yeah, their ladder truck was actually in 9/11. Their old one? Yeah, maybe it was before they purchased it, but yeah, it was actually at ground zero. Yeah.
Very rare circumstance. In those situations, our protocols are like, so our protocols, we're licensed for the state of Vermont. So if we go to a situation over in New York, we still have to abide by our protocols. So it's kind of quirky. We're not really set up for it, honestly. But
Kind of like the XAU thing we were talking about, the IMS, whatever.
yeah,
Got
yes,
it.
yeah. So we'll go grab that stuff, and then we'll go over proper donning and doffing techniques, and then some of our safety equipment that we use. So you guys can take like a 5-minute break.
So Greg, I'll share a login and everything else is ready. I just want the big pen back. You can just rest of that.
Does that come from my office?
No. Came from mine.
This is the active shooter training that we went through. This is all the national training of Senator New Mexico. And it goes up to 1, 2, 3 levels. To the point where we were actually the second class to get these vests and headgear, and it basically you're tuned up. So your weapon and my weapon, if I hit you, you'll feel everything that's a shot.
Yeah.
To the point where it's a taser hit. So when you get to the level 3, you take a hit, you're going down. And it hurts. Sting. Because we all have to go through the training. No, I'd rather be tased one time an hour for 24 hours to get no seats.
I hate getting no seat.
I hate it. I did like 5 years of I'll be the weapons instructor, you have to get certified. Another one straight, take.
Yeah, you just said that, we're gonna start with this first.
Okay. You wanna be the mannequin?
I can't.
Okay.
No, I can put it on. I'll show them my respirator too.
Alright, you got yours.
Yep.
Okay, alright, so we're gonna go over proper donning and doffing procedures. We're doing this stuff. The whole point of this is basically to protect yourself whenever you're taking your equipment off, and then also looking to see how everything goes on appropriately. Has anybody done all this before?
A little bit.
Okay, so we'll show you all here. We had to go through this training about 100 times once COVID hit.
Is that it?
Alright. So, first thing, every call we go to, what are we wearing?
Gloves.
Gloves. Anything else?
Mask.
Mask.
What kind of mask?
Surgical.
And
Surgical mask. At least a surgical. Okay? And then it's also highly recommended. I have glasses, so I can't wear these. So I wear either one of these guys. Okay? So, first thing I do, I put on my first set of gloves. So let's say I'm going to a COVID positive patient, or I'm going to a really bloody trauma. So I've got my gloves. Donning wise, it doesn't matter quite as much because everything is sterile, not contaminated.
Just like everything at the end, you're fine.
So I start.
Red stuff is cherry flavored, right?
Yeah.
Yeah, okay.
If it's wet and sticky, not yours, don't touch it.
That's what I was talking
Pretty good
about.
rule, isn't it, Brad?
Yeah.
What's this? So these ones, it's basically what the state provided us with. So with these ones, these are vinyl coating on the outside, so nothing can get through, wet or whatever. I mean, if I jumped in the lake with this, then yeah, I'm gonna get wet. But basically, it kind of uses your partner for this. So here's performing CPR. This is not fun. Give me the long one. There we go. Some of these gowns you have to tie behind your back. You'll learn to do that.
At what point are you deciding what to wear and putting it on?
It's basically what we're dispatched to right now. Prior to kind of COVID settling, it was we had to wear this with every call. Separate from COVID, it was basically kind of what we're dispatched to. If we know we're going to a gross bleed or childbirth or anything like that, that we're putting this stuff on.
So you're putting that on when you get to the scene, but before you go in?
Yeah,
Okay.
once we get to the scene.
And sometimes if it doesn't sound like a COVID call and you get there and they start answering questions or COVID-like symptoms, then we'll back out and we'll put this stuff on.
Yeah.
We'll say, give us a minute, we're gonna go don it.
So we're doing that 6-foot distance, asking our immediate questions, any recent fever, cough, shortness of breath, abdominal pain, nausea, vomiting. If they say yes to any of that stuff. Any risk of COVID exposure. If there is a risk, then, okay, we're going to back out a minute, we're going to put all our stuff on, and then we'll come in.
But dispatch is really good at asking those questions, so a lot of times we know well in advance.
Right before we get there. Alright, so then the next thing I'm going to do is my N95.
Some of us also have 3M respirators that are multi-use instead of the N95s, where you can only use 3 times in a certain way. I have this one, reusable filters. It works really well. I like it. It doesn't fog up my glasses, so some people do use these.
So I'm fit tested to this one. This is a 1860 NIOSH approved, made by 3M. This one's a regular size. There's either regular or small, so I'm fit tested approved to this one.
There's also duck bills, which
Yeah.
are these. There's different variants of these. There's
240.
they
Oh yeah.
fit testing. It usually takes a while because you got to find the exact one. And
Yeah, it's kind of a pain. So, first thing I do, I put my N95 on, pinch to make sure I got a good seal. You can test yourself. Put your hand around the outside and take a deep breath. You shouldn't feel any heat or whooshing of air. That's so you know you have a good seal. If I'm getting smells right now, then I know I don't have a good seal. Okay? And then the next thing I'm doing,
other than bad breath.
other than that, then I'm putting this over my N95. I like this face mask as opposed to that one. It doesn't clog up my glasses so much. And then I also do the second set of gloves.
Is this your preference or is this EMT's protocol?
This is state's requirements. So this is recommended by the CDC, and the state adopted this, that this is what you wear on a COVID or...
For COVID,
Yeah,
not,
or...
not every call.
Yeah, not every call. No.
Well, when COVID first hit, every call.
Yeah, everything
Yeah.
is,
But a lot of times on cardiac arrest or gory traumatic scenes, double glove, because that way you're not going back to the truck after you dirty them, you just pull them inside out. I always keep a spare set in my pocket just in case. Hand them out, reuse them, that kind of thing. So
unfortunately, you sweat like crazy in this, especially when you're in the back of the ambulance performing CPR. Kind of part of the nature where you got to take a sweatshirt off or whatever, do what you got to do. But yeah, so this is what you should look like if you're going to a COVID positive or a heavy trauma or anything like that. This is what we're wearing.
and cardiac arrest, and also anything that involves aerosolized or intubation procedures. So if you're breathing for them, you're doing anything like that, this is what you're supposed to wear.
Any questions with this? It's a lot of fun. But,
Any suggestions about how to not have your glasses fog?
so the biggest thing I found, as long as you have a good seal, your glasses shouldn't fog up.
Because that's the N95, like this kind of a mask.
So
Right.
the surgical mask, what I do is I put the glasses almost on the bridge of my nose, and that helps so it doesn't fog up.
Tuck your
Get
mask
these online,
underneath.
and you just, it can be adhesed,
Uh-oh.
but I actually had it sewn in, and this thing keeps, I've got the, I can see far, but I can't see a menu.
Right.
So, but this thing keeps your glasses from fogging up, it's just
Yeah.
a little nose bridge, and it just lets the air vent out.
Yeah.
You can also just take a piece of surgical tape or medical tape.
Oh, yeah? The only crappy thing about those
Or don't
is...
breathe.
Yeah, the hospital, you can't wear those into the hospital, which is a pain in the butt.
I carry those in my pocket.
Because sometimes, like, some of those have filters built in and everything, and they're better than these, but for some reason the hospital only requires, or has us require these.
Yeah, you go on those ones that look like Darth Vader and everything,
Oh, yeah.
all the filters and all that stuff, and as soon as you go into up the hill, it's like, oh, here, put one of ours on.
Yeah.
Whatever.
Oh yeah. Their policies, their
Whatever.
requirements.
You're gonna give it to me, I'll put it.
Yeah.
Yep.
Pretty much. So that was technique of putting on. Like I said, it doesn't matter quite as much because you're not exposed or anything like that. But what does matter is doffing. All right. So donning. Now we're gonna doff. I'm grabbing that up.
Trash can?
Yeah.
The biggest thing about doffing is anything that's on the outside, consider contaminated. Do
Yep.
not touch it. Gloves, masks, everything, it's considered contaminated.
So the reason we wear two sets of gloves, other than prevent our exposure. First thing I'm doing.
You've been touching the patient now.
Yep. So now I'm considered contaminated. So my inside of my glove is good. Okay? There's multiple ways of doing this. The main thing is you don't want the outside, which is now tucked in, to touch anything on me. Okay? So whichever works best for you, doesn't really matter. The biggest thing is you just don't want to touch yourself. All right, so now I've got a clean set of gloves underneath. Okay? So now my clean set of gloves, I'm taking my face shield off. Okay? So
That
now
would get trashed?
that would get trashed, yeah. Everything's clean in here, but just to show you, it would get taken off and you would put it into a biohazard bag. Okay? Regular trash, no go. Anything contaminated, especially with COVID, goes into a biohazard bag. Okay? Makes sense? So, I'm going to take my glasses off. Those would have to be deconned. And then from there, my gown. So I tie my gown like this, so that way I can pull the string, it comes undone. And then I'm pulling my gown away from me, okay? I don't want my gown touching my face or anything like that. So the inside of my gown is still considered clean. Outside of my gown is a no-go. Okay? So now I'm just rolling it up into a ball. And I'm using the inside of my gown to remove the other part of my gown.
HealthNet has a really good video about donning and doffing PPE. I'm pretty sure some of you have already seen it, but we had to watch it as an AMCARE requirement.
Yeah. So then the next thing I'm going to do, I'm going to take my gloves off because now I'm considering these contaminated. And I'm using my finger to take the inside of my glove out, and they just go in the trash. Then, clean your hands, perform good hand hygiene, and then we can take our mask off. First,
Using gloves because that was exposed, wasn't it?
what's that?
No, you don't have to with the gloves because he's going to show you the appropriate way and how to do it. He never touches the front. He loops his hands around the back and on the inside. So he never touches the front.
This comes to the front,
Okay,
this comes off.
got it.
And then, if you went to a COVID positive patient in the trash, if you're going to a suspected but not determined, especially when there was an N95 shortage, these would go into a
Brown paper bag for 72 hours, and you can reuse them up to 3 times.
right. So the biggest thing is just preventing exterior exposure, touching you. So then after that's all off, wash your hands again.
And this is not so much for you because you've been vaccinated. This is more if you got it from some patient, you're not going to spread it because you've been protected.
Yeah, you don't want to bring these back here. You don't want to bring them back to your family.
But you must feel better.
I do. We still have to do it though. Yep. Just because I'm vaccinated doesn't mean I can't get it.
Right,
It's just
95.
preventing.
It's not 100.
Yep, exactly. So, any questions with that? It's time consuming. It sucks, especially if our patient's dying on us. But remember, we got to protect ourselves before we can take care of the patient. Okay?
And never bring this stuff, contaminated stuff, in the front of your truck. Your truck should be sealed.
For the love of God.
We have plastic breaking the truck and everything like that, so do not ever put this stuff in the front of your truck.
Yeah. And I hate when I see ambulance personnel wearing their gloves driving the ambulance. It drives me absolutely nuts. Because everything they just did, they're now bringing to the front of the compartment. It kills me. I hate seeing that. So whenever you're done taking care of the patient, if you're going to drive the ambulance, take everything off, leave it in a biohazard bag or in the back of the ambulance, and then wash your hands, then proceed to go to the front of the ambulance.
And after every call, we spray the back of our trucks and the front of our trucks. Even if nothing got in the front, we still spray it down.
You using a fogger? Or?
No, the hospital has spray bottles, but
Hot cyber.
yeah.
Okay.
We used to have an aerosolizer at UVM. If you guys haven't seen it, it's a little machine that would go in the patient compartment. You just turn it on and it completely defogs the entire ambulance. It was great. We ran out of whatever the fluid was.
Within like a week.
Yeah. Because they were
Well,
doing
that's a lot of
everything.
calls. You got yours pre-mixed or do you mix your own?
It was all provided by UVM, so I'm guessing pre-mixed.
Yeah, because we have to mix our own.
Yeah.
And it's like a big process.
It is very time consuming, but
you get that stuff on you, it's gonna burn.
Yep.
But if deconning, sometimes it takes us 45 minutes, but you got to make sure your back of your truck's clean, front of your truck's clean, yourself is clean before you go to the next
Take
call.
time.
Yep.
Clean your ambulance.
We've had crew at the hospitals deconning, cardiac arrest came in, they had to wait, and you sent another truck out, but then you got to have your truck clean.
Yep. So, yeah, when we had that aerosolizer, whatever was in the back of the ambulance, whether it was my phone or my stethoscope, whatever, throw it all back there. It's all got to be decontaminated. Okay?
That sounds handier.
It is a lot. It makes it a lot easier.
Yeah,
we don't have it anymore.
Yeah.
So now it's just a lot of wiping. But you got what you got. So, that is our personal body substance isolation. This is some protective equipment we use. If you haven't worn a Kevlar vest before, these are ours. They're kind of a pain to put on. I'll put it on.
Yeah, we have 2 on each truck. They're provided, there used to be St. Albans PD's old vests. They are a big pain in the butt to put on. I got here. See which.
That goes too far. Oh, there you go. You got it. There you go. These things are extremely heavy. They're not fun to wear. As cool as they are, they're heavy. They're not fun to sweat. So name me a situation where we would have to wear this. Active shooter. Perfect.
A lot of times we'll even wear these on standbys. Like we had one the other day, a guy with a knife. We put it on just in case. We didn't go in, but we still had it ready
Yep.
just in case.
We had a bomb situation. Every crew that was there had to wear a Kevlar vest. With that bomb scare. So.
We have a lot of those too.
Yep.
Got a lot of them.
So you can see Russ, so if you notice, his vitals are protected, right? His heart's sitting here, his lungs, his vital organs, and his abdomen. What's not protected?
Head, pasture.
It's not vital, it's okay.
So keep that in mind. It's protecting everything here. It's not protecting his head. It's not protecting, subclavian artery and all that stuff. So just keep that in mind.
A little bit helps.
A little bit helps, absolutely. But this is one of the things we wear, so if we are going to an active shooter situation, we put this on. We're not running into the scene. I've got Kevlar, I'm good to go, let's roll. That's not what we do. We wait for PD to clear us before we go in. We're not going into hot zones. You guys understand hot zones, warm zones, that kind of stuff? So we're certified to go into warm zones. And what I mean by a warm zone, PD is dealing with an active shooter, and that active shooter has gone off somewhere else. They don't know exactly where he is, but they know he's not where they want you to go. Okay? So a good example would be a school. If there's an active shooter in the school, they know he's not in the west wing of the school, he's in the east wing. And we've got multiple patients in the west wing.
PD goes with you.
PD goes with us. We work as a team. There's 2 of us that go. I've got an officer in front of me, I've got an officer behind me. They're in control. They're telling us if we need to get out, if we need to get down.
Your secondary guys, you got your front guys that are already going through and they're just blazing through.
Yep.
They don't stop for anybody.
Right, exactly.
It's like they don't stop to help anybody, they just go.
Yep.
That's what you do.
And we'll get into MCIs and that kind of stuff, but with that, our protocols and our treatment's different because now we're in an MCI situation where it's triaging. Triage, 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 identifying what you have, who needs immediate treatment, that kind of stuff. So this is the bag we carry in with us. This is our tactical bag. So it's got a carry tarp. So basically, we fold this out. It's got handles on the side so we can drag patients out. We've also got a lot of tourniquets. So we carry 20 tourniquets in each bag. Every truck is equipped with this, along with the 6 other tourniquets in other bags. We're going to teach you how to apply tourniquets, when to effectively apply them, how to reassess them, that kind of stuff.
Quick clock.
Quick clock. So this is combat gauze. This is stuff we use if somebody's got a penetrating wound, actively bleeding. We use that to try and close the wound.
Israeli's the best.
Is that new? Because a while ago I thought that Quick Clot wasn't approved in Vermont, or at least in District 1.
It is situation dependent.
Okay.
So we're not going to use it day to day on every patient.
Yeah.
It's more for active shooter situations.
There are some drawbacks to it, right? Well, somebody can move.
Life over limb.
Okay.
That's what we're doing it for.
Yep. Okay.
You have to be
For
ready
its
to use-
intended purpose, no. But it could draw some negative things if you use it wrong or
Yep.
anything like that. So.
You get trained on this.
Yep.
We're all gonna, okay.
First thing out of the gate with the quick clock is you're going to have to react to the patient. If they're not unconscious, if they're conscious, they're going to feel pain. Because that's the whole purpose, it's just searing.
Yep. The other thing we have, anybody recognizes these? Anybody know what these are?
Those are for in and out chest wounds.
Chest seals. Alright, and actually these,
Or in and
we'll
out.
pull it right from this kit. If we have, a chest wound, we'll use it right from this kit.
Is that the enter and exit wound?
Yeah, no, it's only one side, so you gotta do one
Oh.
each.
Okay, that's not for a sucking chest wound.
Yes.
It is, okay.
Yep.
It's 3-sided.
So this is actually has a valve
Oh,
in the middle of it.
fantastic.
So it allows air out, it doesn't allow air in. We're gonna go over all that, I'm not expecting you guys to all know that, night 1, but.
That's
this is
actually
just to
night
show
2.
you. Night 2. Right, and then the other thing is just a set of trauma shears. But when we're talking about our protection, making sure you have the equipment you need for the situation. If you don't have it, and it's putting you in danger, then back out of the situation. Okay? And the other thing is hazmat fit good. Any questions with any of this stuff?
You're gonna be carrying a different bag most of the time for
Yes.
non-shooting situations, which will have others, you know.
Yeah, I've only held this bag once,
Okay.
but we have two other bags on our trucks. We have a
Yep.
red bag and a green bag.
Yep.
Red bag pretty much goes in every call, has our drugs and certain equipment and everything, and then the green bag's more of trauma, cardiac arrest kind of stuff.
Okay.
And every agency kind of sets up their,
And everything goes on the gurney and you roll it in with you.
if we get the gurney in the house.
Okay, otherwise you're heading into the bags.
A lot of times we'll get the gurney after, and we'll go see what we have and see what's going on. So usually we just bring the bags and the monitor kind of thing.
Any questions with any of that stuff, guys?
Thank you.
That's all we have for tonight. Joe already updated you on the syllabus. You have your books, do the reading. We covered chapter 1 and chapter 2. Those quizzes will be due at the end of May. Okay?
Are they open to go into, because a little while ago?
Yes, you should be open to going to, yeah.
Okay.
Be open them up.
If they are, don't worry about it. Just don't tell anybody.
Well, I tried like a half an hour ago when you guys were talking, and
And it didn't do
it
it?
didn't let me in. So,
Was it for tonight or for previous?
both of
They
them.
didn't let you in.
No.
Okay. I'll talk
So
to
we
you
have to do
about
like
that.
some sort of homework first.
Yeah, so you have the reading, which is basically just going through the reading material, and then after every chapter, there's a post quiz. Those are your 2 assignments, so
Okay. So how do I tell it that I've read it?
it'll come up on your grade.
Would you say
You
that's
speak
new?
softly, say nice things.
The chapter's
I can
Chapter
show
1 and 2
you.
quizzes.
Okay.
It'll show it due date on your MyLab.
Oh, okay.
We set it for.
It's like trying to start your first car. Just rub the hood a little bit.
Stroke it?
I'll have Derek send you guys an email just to make sure you guys are
Put some coke in the battery.
Right corner,
Yeah,
yeah.
you got a little, you got a little works.
I live like not even 30 seconds away.
I haven't had any mechanical ability to the work there. Carburetor. I have no idea.
I can't, yeah, I can't.
They don't care either.
Yeah, I'm a state legislator.
The older cars that I had to work on them. I got.
Now you gotta be careful what you say to them.
And then I got warranty
I
and
didn't do a
stuff.
job on them, that's
My best friend.
Well, I pass a lot.
1960
That's a
Dodge
prerequisite.
Comet.
Um,
We split
No, I
250 bucks
love
a piece,
policy
500
making.
bucks.
The policy
I had
writing,
like
policy
3
making
months.
side of it is when I got my
Carburetor
degree.
when I was able to
Um,
slant 6 and everything.
The case law, the interaction
So we
of
had someone we got to
making
be sent
policy
there
and
down
your
in his old
primary,
man's,
secondary,